Hello and welcome to our webinar on navigating the ins and outs of annual wellness visits. My name is Jennifer Boniface and I am one of the registered nurses with the Provider Outreach and Education team. Today's webinar will focus on the documentation requirements for the Medicare Part B annual wellness visits. The annual wellness benefit under Medicare Part B plays an essential role in promoting preventive health care for Medicare beneficiaries. It allows healthcare providers to assess the patient's current health status, identify any potential risks that may be present, and then create a personalized prevention plan for the patient. Our objective for today is to explain and review documentation guidelines for the annual wellness visit. And we will discuss Medicare coverage criteria and documentation guidelines for the annual wellness visit, optional components of the annual wellness visit, including advanced care planning service and physical activity and nutrition risk assessment, and documentation guidelines for the health risk assessment. We'll then finish up by reviewing documentation examples for the annual wellness visit. Let's begin with discussing who can conduct the annual wellness visit. This visit must be performed by a qualified health professional. According to the Medicare Benefit Policy Manual, Chapter 15, Section 280.5, the term health professional includes a physician who's a doctor of medicine or osteopathy, a physician assistant, nurse practitioner, or clinical nurse specialist, or a medical professional, including a health educator, registered dietitian or nutrition professional, or other licensed practitioner, or a team of such medical professionals working under the direct supervision of a physician. So direct supervision by a physician means the doctor is physically present in the office and readily available to provide assistance and guidance throughout the procedure, even if not in the same room as the patient. And a link to the Medicare Benefit Policy Manual, Chapter 15, has been provided on the resources slide at the end of the presentation. Medicare covers the annual wellness visit for beneficiaries enrolled in Medicare Part B who do not fall within the 12-month period following the effective date of their initial Medicare Part B coverage period and have not received an initial preventive physical exam or annual wellness visit in the previous 12 months. In other words, patients are eligible to receive an annual wellness visit every 12 months. For Medicare to cover the cost of the annual wellness visit, a minimum of 11 full months must have passed since the patient's last visit. The first or initial annual wellness visit, G0438, is covered once per lifetime. Subsequent annual wellness visit, G0439, an annual wellness visit in a federally qualified health center, G0468, are covered once every 12 months. There is no copayment, coinsurance, or deductible for the annual wellness visit, provided it is performed by a healthcare provider who accepts assignment. Annual wellness visits G0438 and G0439 are telehealth eligible. The requirement can be met through audio-only interaction. So let's review the components required for the first or initial annual wellness visit. The initial annual wellness visit includes the review or administration of the health risk assessment, along with 12 additional components. At a minimum, the visit begins with a review of the patient's medical and family history. This includes past medical and surgical history, family history, including review of hereditary factors that may place them at increased risk, and current medications, supplements, and other substances the patient may be taking. A list of all current healthcare providers and suppliers is also documented, including behavioral health specialists, to support continuity of care. Next, patient measurements are completed. These include height, weight, body mass index or waist circumference, if appropriate, along with blood pressure and other routine measurements based on the patient's medical and family history. An assessment for potential cognitive impairments is also conducted, along with screening for depression or other mood disorders using standardized tools endorsed by national medical organizations. The provider then reviews the patient's functional ability and overall status. This includes checking for hearing impairments, evaluating their ability to perform activities of daily living, assessing fall risk, and reviewing home and community safety, including driving when appropriate. For patients that display signs of cognitive impairment, Medicare provides coverage for cognitive assessment and care plan services. An important part of the visit is the creation of a written screening schedule. This schedule should be developed to include all necessary screenings for the next 5 to 10 years and should be based on recommendations from the U.S. Preventive Services Task Force and Advisory Committee on Immunization Practices, along with information from the patient's health risk assessment, health status, screening history, and age-appropriate preventive services covered by Medicare. A list of risk factors and conditions is identified and documented. This includes a recommendation for primary, secondary, or tertiary interventions, while also indicating any interventions that are currently underway. It also includes assessing mental health conditions such as depression, substance use disorders, and cognitive impairments, and reviewing risk factors and conditions identified during the initial preventive physical exam, along with potential treatment options and their associated risks and benefits. Personal health advice is then provided, along with referrals to appropriate health education and preventive counseling services or programs for community-based lifestyle interventions. Patients may receive recommendations related to weight management, nutrition, physical activity, tobacco cessation, social engagement, cognitive health, and fall prevention. Another essential component of the visit is a review of current opioid prescriptions. This includes evaluating potential risk factors for opioid use disorder, assessing pain intensity and the current treatment plan, and providing information on non-opioid treatment options. Referrals to specialists are provided when appropriate. For patients with chronic pain, Medicare Part B also covers monthly chronic pain management and treatment services. Next, the visit involves a screening for potential substance use disorders. This includes reviewing any risk factors and making referrals for treatment when appropriate. While the screening tool can be used, it is not required. Finally, the visit may include optional services such as advanced care planning and physical activity and nutrition risk assessment. In order for the visit to meet billing requirements, all elements of the annual wellness visit must be addressed. Claims missing any required documentation components may not be eligible for coverage upon review. Healthcare providers must ensure all required components are clearly and thoroughly documented. Before we move on, I want to address a few pre-submitted questions we received. So the first question asked if it is necessary for the patient to complete a form with details such as past medical history, past surgical history, and current medications, or can the provider obtain this information by reviewing the patient's chart or asking during the annual wellness visit? And this information mentioned can be obtained either through a form completed by the patient, discussing it with the patient during the visit, reviewing the chart, or a combination of these. To ensure the information provided is accurate and up to date, always verify it by reviewing the patient's medical record. The next question asks, do providers need to go back through the medical record looking for other providers involved in care, or is it okay for the provider to query the patient? For a Medicare annual wellness visit, providers are not required to conduct an exhaustive search for records from every outside clinician a patient may have seen. The visit is primarily based on information obtained from the patient on records already available within the provider's system. Providers should ask the patient to identify other clinicians or suppliers involved in their care. When external records are readily available and relevant, they should be reviewed and incorporated as appropriate. Providers should also review and update any existing information in their own records. The goal is to maintain accurate documentation and coordinate care using reasonably available information. And the third question asks, when documenting updates to the patient's list of risk factors and conditions, does the provider need to include the status of every single chronic problem, or is updating the problem list in the EMR sufficient? During the annual wellness visit, the provider should review and update the patient's medical history, problem list, and risk factors, including chronic conditions when appropriate. While Medicare requires documentation of these components, it does not specifically require a detailed status update for every chronic condition at each visit. However, documenting active and clinically relevant chronic conditions supports accurate coding, continuity of care, and a complete picture of the patient's overall health. Providers are encouraged to be thorough in their documentation to provide the best care possible. The optional advanced care planning service is a voluntary face-to-face conversation between the healthcare provider and the patient regarding advanced directives. An advanced directive outlines the patient's preferences for future medical treatment in the event they are unable to make decisions at that time. The patient may appoint a representative to make healthcare decisions on their behalf if needed. Both the annual wellness visit and the advanced care planning service are considered preventive services if provided on the same day by the same healthcare provider. Additional information about advanced care planning can be found on MLN 909289 Advanced Care Planning Fact Sheet, and a link to this MLN document is available on the resources slide at the end of the presentation. When documenting the advanced care planning visit, be sure to include an explanation that the advanced care planning conversation was voluntary, documentation confirming the patient fully understands the process and their available options before making decisions regarding advanced care planning, description of advanced directives, documentation of the patient's wishes for future medical treatment in case they're unable to make their own decisions, documentation of time spent performing the face-to-face advanced care planning visit, list of all participants present during the advanced care planning visit, and documentation of any changes in the patient's health status. Advanced Care Planning Services, CPT code 99497 and 99498, when billed with an annual wellness visit, are covered annually. There is no copayment, coinsurance, or deductible for advanced care planning when provided on the same day by the same provider and billed on the same claim as the covered annual wellness visit using modifier 33. However, if the annual wellness visit and advanced care planning service are billed on the same claim and the annual wellness visit is denied because it exceeds the once per year limit, the advanced care planning service will be subject to deductible and coinsurance. It's also important to remember that the advanced care planning service does not have to be provided only during an annual wellness visit. It can be delivered as a separate service and may occur multiple times throughout the year whenever the patient's needs or circumstances change. When provided separately, deductible and coinsurance will apply. In addition, advanced care planning services may be delivered through telehealth, providing greater flexibility and accessibility to patients. Finally, it's essential to document any changes in the patient's health during each advanced care planning visit. The physical activity and nutrition risk assessment is an optional part of both the initial and subsequent annual wellness visits and can be completed during the same appointment. Medicare covers this assessment under HCPCS code G0136. It is the administration of a standardized, evidence-based assessment of physical activity and nutrition lasting 5 to 15 minutes and may be performed more frequently than every 6 months. The assessment may be completed at the discretion of the patient or the clinician. This assessment may be performed by any provider who meets the definition of a health professional in accordance with 42 CFR section 410.15a, including a physician who's a doctor of medicine or osteopathy, a physician assistant, nurse practitioner, or clinical nurse specialist, or a medical professional or a team of such medical professionals working under the direct supervision of a physician. Medicare permits clinicians to perform a standardized physical activity and/or nutrition assessment for patients when there's a known or suspected concern regarding their activity level or nutritional status. This service is not intended for routine screening of all patients, but should be used only when clinically warranted. The service may be billed when both assessments are completed or when only one assessment is clinically reasonable and necessary, such as when a patient has started a new diet but has yet undergone a physical activity evaluation. These assessments may be performed during an annual wellness visit, an evaluation and management service, or certain behavior health assessment visits. When performed during an annual wellness visit, the physical activity and nutrition risk assessment is covered once per year. There is no coinsurance or deductible when it is provided on the same day and by the same provider as a covered annual wellness visit. When billed with the annual wellness visit, the physical activity and nutrition risk assessment must be submitted on the same claim as the annual wellness visit using modifier 33 to indicate a preventive service. If the annual wellness visit is denied because it exceeds the once per year limit, the physical activity and nutrition risk assessment will also be subject to deductible and coinsurance. Medicare allows the physical activity and nutrition risk assessment to be billed once every 6 months, but only when it is performed with an evaluation and management service or behavioral health service and is submitted on the same claim. When the assessment is performed outside the covered annual wellness visit, deductible and coinsurance will apply. While a standardized physical activity and nutrition risk assessment form from CMS is not yet available, healthcare providers have access to a variety of evidence-based tools to help with completing these assessments. For nutrition screening, several validated tools are commonly used. For example, the Mini Eat tool from the Mayo Clinic provides a quick way to evaluate dietary intake and nutrition-related behaviors. Another option is the Starting the Conversation Diet tool, developed by the Center for Health Promotion and Disease Prevention at the University of North Carolina at Chapel Hill in collaboration with the North Carolina Prevention Partners. This brief screening instrument helps guide discussions about dietary habits and encourages healthier eating patterns. For adults aged 65 and older, the Mini Nutritional Assessment, or MNA, is widely used to screen for malnutrition or risk of malnutrition. Its short form includes 6 questions, allowing for a quick yet effective evaluation of nutritional status. When it comes to physical activity, providers can use a tool such as the CHAMPS Physical Activity Questionnaire for older adults, which assesses the type, frequency, and duration of activity in older populations. In addition, the University of Washington Health Promotion Research Center has developed 2 tools for assessing physical activity: the Rapid Assessment of Physical Activity and the Telephone Assessment of Physical Activity. Both offer brief and efficient ways to evaluate activity levels. The telephone assessment of physical activity also allows for phone-based administration, making it useful for remote or large-scale assessments. So now let's address another pre-submitted question we received. The question asked, will asking the social determinants of health questions satisfy the physical activity and nutrition risk assessment? If not, what is required? In general, the answer is no. Questions related to social determinants of health do not automatically meet the requirements for the physical activity and nutrition risk assessment. For this assessment, CMS requires the use of a standardized evidence-based assessment tool that specifically evaluates a patient's physical activity and/or nutritional status. Examples of tools that may be used are listed on this slide. The purpose of these assessments is to identify physical activity and nutrition needs that could affect a person's diagnosis, treatment, or overall health outcomes. Because of this, the assessment must be based on a validated screening tool and cannot rely solely on broader social risk or social determinants of health questions. Now that we've reviewed the initial annual wellness visit, let's turn our attention to the subsequent annual wellness visit. The documentation for this visit is very similar to what is required for the initial AWV. First, it includes, at a minimum, the completion or review of the health risk assessment. Next, the provider updates the patient's medical and family history. This includes past medical and surgical history, a review of family history with attention to hereditary risk factors, and an updated list of current medications, supplements, and any other substances the patient may be using. The visit also involves updating the list of current providers and suppliers who regularly participate in the patient's care. This includes any providers added after the initial annual wellness visit and any behavioral health professionals involved. In addition, routine measurements are obtained. These include weight or waist circumference, blood pressure, and other relevant routine measurements based on the patient's health status and history. The visit also includes screening for cognitive impairment to detect any potential concerns. Another important component is the updated written screening schedule, which is based on recommendations from the U.S. Preventive Services Task Force and Advisory Committee on Immunization Practices. This schedule also incorporates findings from the patient's health risk assessment, medical history, screening history, and Medicare-covered preventive services appropriate for their age. The documentation should also be updated to reflect current risk factors and conditions. This includes a recommendation for primary, secondary, or tertiary interventions, as well as noting when interventions are currently in progress. It also addresses mental health conditions such as depression, substance use disorders, and cognitive impairment, as well as other identified risk factors and conditions. Treatment options are reviewed along with their potential risks and benefits. Patients are also provided with personalized health advice and, when appropriate, referrals to appropriate health education and preventive counseling services or programs for community-based lifestyle intervention. And these may support weight management, physical activity, nutrition, tobacco cessation, social engagement, cognitive health, and fall prevention. The provider should also complete a review of current opioid prescriptions. This involves assessing risk factors for opioid use disorder, evaluating pain severity and the current treatment plan, discussing non-opioid alternatives, and making referrals to specialists when appropriate. And remember, Medicare Part B also covers monthly chronic pain management and treatment services for patients who have chronic pain. Screening for substance use disorders is also conducted, including assessment of risk factors and referral for treatment when needed. Finally, the visit may include optional services such as advanced care planning and physical activity and nutrition risk assessment. Again, remember, all elements of the annual wellness visit must be addressed in order for the visit to meet billing requirements. Documentation guidelines for both the initial annual wellness visit and the subsequent annual wellness visit is available on our website, and a link to this information can be found on the resources slide at the end of the presentation. Let's now take a closer look at the health risk assessment. The health risk assessment, or HRA, assists the healthcare provider with identifying the patient's health behaviors and potential risk factors. Completing the HRA allows providers to review identified concerns with the patient and then take steps to address them, potentially reducing the risk of related diseases. The data collected in the HRA is provided by the patient and can be filled out by either the healthcare professional or the patient before or during the annual wellness visit. The HRA can typically be completed in 20 minutes or less. This required information can be gathered either through direct patient interviews, patient-completed forms reviewed by clinical staff, or a combination of both. When completing the health risk assessment, it's essential to customize it to meet each patient's specific needs, including those with language barriers, health literacy challenges, or disabilities. Components of the HRA include demographic data, health status self-assessment, psychosocial risks, including but not limited to depression and life satisfaction, stress, anger, loneliness or social isolation, pain and fatigue, behavioral risks, including but not limited to tobacco use, physical activity, nutrition and oral health, alcohol consumption, sexual health, motor vehicle safety, including seatbelt use, and home safety, activities of daily living, including dressing, feeding, toileting, grooming, physical ambulation, including balance or risk of falls, and bathing, and instrumental activities of daily living, including shopping, food preparation, using the telephone, housekeeping, laundry, motor transportation, responsibility for own medications, and ability to handle finances. Be sure to address each of these components when completing the HRA to confirm that all required documentation has been completed. And for more information regarding the components of the health risk assessment, please refer to 42 CFR section 410.15, and a link to this resource has been placed on the bottom of the slide for your reference. We received 2 pre-submitted questions regarding health risk assessments, so before we continue with the webinar, I'd like to answer those first. So the first question asked, does both the provider and the patient need to sign the health risk assessment? And only the provider needs to sign the documentation. The other question asks, for the health risk assessment, if the demographics are listed all over the patient's chart, for example, female, age, etc., do we need to have this on the health risk assessment? And as long as the information can be found in the documentation and it's submitted if requested for review, the demographic information can be anywhere within the chart for that date of service. So before we proceed to documentation examples, I want to address 2 common questions we received regarding requirements in federally qualified health centers and rural health clinics. The first question asks if the requirements are different for federally qualified health centers when completing a Medicare annual wellness visit. Federally qualified health centers follow slightly different Medicare billing rules for annual wellness visits, but the visit itself still needs to include the same required clinical components as it would in any other setting. FQHCs use code G0468 for billing annual wellness visits, as well as for billing the initial preventive physical exam. This code is reimbursed under the FQHC prospective payment system, which includes a bundled payment for each of these preventive services. To receive reimbursement, FQHCs must ensure that all AWV requirements are fully completed and documented. The other question asks which providers can perform the annual wellness visit in an FQHC and which providers can perform the annual wellness visit in an RHC. To bill an annual wellness visit in an FQHC or RHC, the service must meet the facility's encounter requirements, which generally include a face-to-face encounter with a qualified practitioner. For an FQHC, the service must be provided by an FQHC qualified practitioner, such as a physician, physician assistant, nurse practitioner, or clinical nurse specialist. For RHCs, these same practitioner types are also eligible to provide the annual wellness visit. Other medical professionals may perform components of the annual wellness visit as part of the care team under the direct supervision of a physician, but cannot independently bill the visit. You can find a list of all eligible practitioners for FQHCs and RHCs in MLN 006397 Federally Qualified Health Center and in MLN 006398 Information for Rural Health Clinics. Now that we've reviewed the coverage criteria for annual wellness visits, let's go over some claim examples. I provided two examples, one that contains all the required information for documenting an annual wellness visit, and another that lacks some of the necessary documentation so you can better understand what should be included when documenting these visits for your patients. As a reminder, since we can't actually see the patient, it's essential you send all the necessary documentation to help us with the claim review process. Our first example is claim number 1. This patient had an annual wellness visit on May 15, 2025. For this claim, all the documentation requirements for the annual wellness visit were addressed. We're now going to take a closer look at each element of documentation used in the review process, and I will highlight key findings within the patient's chart. So on this claim, we have a patient who presents on May 15, 2025, for a subsequent annual wellness visit. On this first page, the patient's health maintenance and preventive screening information is documented. We can infer the patient is female because the preventive services listed include female-specific screenings such as last Pap test and mammography. She was educated on vaccines during this visit. She also completed her mammogram on the date of the annual wellness visit. The note was electronically signed and dated for the date of the visit. At the bottom of the page, we find the physical exam. Here we can see the patient's date of birth documented, which indicates that she's 69 years old. Next, we can find the patient's current medical problems. So right here, we have all the patient's current medical problems. I'm just going to scroll through them. In the assessment and plan section, we can find more detailed information about each of these conditions. So this chart has all the problem list, but it has everything defined, what was done, and some subjective, objective information for each of these diagnoses. So we'll scroll through that. On page 4, the patient is again identified as a 69-year-old female presenting for an annual wellness visit and an annual exam. So next we're going to scroll down to the middle of page 5. Here we can see the patient's active medical problems and conditions, followed by the patient's past medical history and past surgical history. Next is a list of the patient's current medications. At the bottom of page 6 and the top of page 7, we can find the patient's family history. Next is the patient's social history, followed by the social drivers of health. We will discuss this information for these topics when we look at the health risk assessment. However, I want you to pay attention to the documentation stated in the patient's report to the documentation that reports the patient is not currently sexually active. So right here. We'll discuss that documentation in a few minutes. So at the bottom of page 8, we have the patient's immunization history. And here at the top of page 9, it shows the note was electronically signed and dated for the date of service. The health risk assessment begins here on page 9. Remember, the information in the health risk assessment is patient reported. So let's take a look at the documentation included for this patient's HRA. The patient's race is documented as white or Caucasian, and her ethnicity is documented as unknown. This completes all the remaining required information needed for the demographic portion of the annual wellness visit. Next, we have a set of vital signs including blood pressure, height, weight, and body mass index. At the bottom of this page and continue on to next, we find the patient's social history. The patient reports that she does not use tobacco or vaping products. Under alcohol use, the patient states that she rarely drinks. She denies drug use and reports that she's not sexually active. She reports a tubal ligation for birth control method. Again, I want you to pay attention to this documentation, and we will discuss it in just a moment. Under social drivers of health, she reports no concerns with finances, food insecurity, transportation, stress, social connections, intimate partner violence, or housing stability. She does report being physically inactive and states that she doesn't engage in any exercise during the week. So I want you to pay attention to the documentation stating that she is physically inactive. We'll discuss this documentation in a few minutes. The annual wellness visit was completed when G0136 was defined as the optional social determinants of health risk assessment and therefore meets the requirements in effect at that time. However, please note that beginning January 1st, 2026, G0136 is defined as the physical activity and nutrition risk assessment. As a result, when clinically appropriate and medically necessary, that assessment should be completed in accordance with updated G0136 requirements. On page 11, we see a list of the patient's current providers. There are no issues documented regarding the patient's oral health or sexual wellness. However, right here, she reports that she is sexually active. Earlier in the chart, she indicates that she was not sexually active, which conflicts with the current documentation. It's important that this information is both accurate and consistent throughout the medical record, because any discrepancies can impact proper care management and may result in claims being denied. So moving on, under motor vehicle safety, the patient reports no difficulty driving. She states she wears her seatbelt when in the car. Under nutrition, she reports that she does have special diet plans. However, it's not clarified what these plans may be. Next, the patient's activities of daily living are documented. She reports no issues or difficulties with activities of daily living or instrumental activities of daily living. So here we can see that she has answered no for all of those. So we know that she does not have difficulties with those activities of daily living and instrumental activities of daily living. She lives with her spouse, and her house does not have any safety issues. Under physical activity, the patient reports that she exercises regularly. However, under physical activity in the social drivers of health section, the patient reported that she was inactive and had no days of exercise per week. Once again, it is important that the information in the records match. Any inconsistencies in the documentation could affect continuity of care and may even lead to claim denials. Under the screening for hearing loss section, the patient reports she doesn't wear hearing aids and does not have any issues with hearing. Right here we can see that her hearing loss screening score is 0 and the interpretation of the screening is negative. Under psychosocial risks section, she reports no issues with stress such as being tense, restless, or anxious. She has no issues with sleeping. She denies feeling anger or feelings of aggression. She denies feelings of loneliness or isolation or symptoms of fatigue. The patient reports that she socializes 3 times a week and goes to church or religious services more than 4 times a week. Her PHQ-2 score is 0 and her depression screening is negative. Her mini-cog screening is also negative. At the bottom of page 12 and the top of page 13, there is a list of preventive screenings along with the dates when the next screenings are due. So here we can see that. Next, we can find documentation that the patient requested additional information about advance directives and was given a booklet on the topic. At the bottom of the page, the note was electronically signed and dated by the physician for the date of the visit. Page 14 has the patient's 5-year plan with a summary of what health maintenance and preventive screenings are due, as well as which ones are complete. So here again, you can see all of that. So after reviewing this claim, it was determined that the required components for the annual wellness visit were found in the documentation sent. This claim was ultimately cleared for payment processing, pending any additional system edits. Now that we've discussed the claim with all the required documentation, let's shift our focus to a claim that's missing some of the necessary documentation for the annual wellness visit. Our next example is claim number 2. This patient had an annual wellness visit on May 12, 2025. For this claim, race and ethnicity were not addressed in the documentation sent by the provider. Additionally, the health risk assessment does not include the required information on psychosocial risks such as stress, anger, loneliness, or social isolation and fatigue. Both of these are required components of the health risk assessment. So let's take a look at this claim and review what documentation was sent for the patient's annual wellness visit. And we'll discuss what documentation was missing after we review what was sent with the claim. So for this claim, we have a 69-year-old male who received a subsequent annual wellness visit on May 12, 2025. Here you can see the patient's date of birth is documented, indicating that he is 69 years old. We can deduce that the patient is male as the physician has referred to the patient as he and his. Next, we have a list of the patient's current medical conditions, followed by the patient's past medical history, surgical history, family history, and social history. Per the social history section, the patient consumes 2 to 3 servings of caffeine per day, exercises 1 to 2 times a week, is a former smoker, denies illicit drug use, and reports occasional alcohol use. At the bottom of page 2, there's a list of the patient's current medications. A list of vital signs, including height and weight, body mass index, and blood pressure, can be found here on page 3. Next, we can see a cognitive evaluation was performed. The results determined a negative screen for dementia. Per his psychosocial evaluation, he denies feelings of hopelessness, feeling down or depressed, loss of interest in activities or pleasure doing things within the past 2 weeks. His functional assessment states the patient is self-reliant in usual daily activities. His fall risk assessment is negative, and he's also negative for the depression screening. Now let's scroll down to the middle of page 5. Here we can find discussion and summary of the preventive services for the patient. The physician noted what screens are needed and recommendations for when they should be performed, along which screens were not needed. So here we can see cardiovascular recommendations, yearly, diabetes twice yearly, prostate yearly. And then we can see the ones that were not relevant to him, such as pap test, pelvic exam, mammography. They do have NA. So the physician has documented that within these guidelines. As we continue down on page 6, we can find a list of the patient's vaccines. At the bottom of page 6, the physician has electronically signed and dated the note for the date of the visit. Now let's review the health risk assessment. Information here is patient reported. Under functional behavioral health assessment, we can see the patient reports his health as good and the condition of his mouth and teeth as very good. He denies any hearing issues. He also reports that he doesn't snore. He doesn't require any assistance with activities of daily living such as eating, dressing, grooming, bathing, or toiling. He also does not require assistance for his instrumental activities of daily living such as laundry, housekeeping, banking, shopping, using the telephone, food preparation, transportation, or medication management. The patient denies any pain, and he also denies any bowel or bladder incontinence. He exercises 1 to 2 times a week and consumes fruits and vegetables once a day. He also states that he does not typically eat high fiber and or whole grain foods daily. So here we can see that information. The patient reports that he is a former smoker. He denies using tobacco products in the past 30 days and denies any current secondhand smoke exposure. The patient reports drinking alcohol one day over the past 7 days and denies consuming 4 or more drinks during one occasion. So here we can see that information right here. He also denies any illicit or illegal drug use. He reports taking his medications as prescribed and does not use someone else's medications, and he is currently not taking any opioid pain medications. Next, we have the fall risk and safety assessment. He denies falling over the past 2 months. His home's main pathway are unobstructed. He reports he does have throw rugs on the floor. There are no missing or broken handrails in his home, and he has working smoke detectors within his home. He is currently not sexually active and has declined sexually transmitted infection screening. He denies driving after drinking alcohol or riding with a driver who has been drinking alcohol. He also reports that he wears his seatbelt in the car and he feels safe from abuse. Under the depression screening section, the patient denies feeling down, depressed, or hopeless, or having a loss of interest in activities or pleasure in doing things in the past 2 weeks. He has a current advance directive and or living will and does not want additional information on the topics. Next is a list of the patient's current health providers and suppliers. At the end of the health risk assessment, the physician has acknowledged that the HRA was reviewed with the patient. The health risk assessment is then signed and dated by the physician for the date of the visit. And the last page of this chart contains a completed clock drawing used for the cognitive evaluation. So now let's take a look what was missing from the documentation. For this claim, the provider did not meet all the requirements for the health risk assessment and therefore did not meet all the requirements for the annual wellness visit. Specifically, the race and ethnicity portion of the demographic data was missing. The demographic elements required for the health risk assessment are outlined in 42 CFR section 410.15. Additionally, the claim lacked necessary documentation of psychosocial risk factors such as stress, anger, loneliness or social isolation, and fatigue. According to the CMS resource Annual Wellness Visit Health Risk Assessment, the HRA must include demographic data as well as documenting addressing psychosocial risks, including but not limited to depression, life satisfaction, stress, anger, loneliness or social isolation, pain, and fatigue. And he did address some of these issues, but he did not, or the documentation did not address all of these psychosocial risk factors. The claim did not include some of the required documentation to support the services as medically reasonable and necessary. And had these components of documentation been addressed, a different conclusion regarding medical necessity may have been made. The Medicare Part B annual wellness visit is a key component of preventive health care for Medicare beneficiaries. During these visits, healthcare professionals assess an individual's overall health, identify potential risk factors, and develop a personalized prevention plan. So as a recap, during today's webinar, we reviewed Medicare coverage criteria and documentation guidelines for the annual wellness visits, discussed the optional components of the annual wellness visit, including advanced care plan service and physical activity and nutrition risk assessment, addressed the documentation guidelines for the health risk assessment, and provided documentation examples for the annual wellness visit. On these next 2 slides, you'll find resources and links related to what we discussed today. Please use them as a reference when reviewing the presentation. So we are now at the end of the formal presentation. If you have any questions, feel free to place them in the chat. And I did see that question, Christy, that you put in the chat, and we are going to address that question during the annual wellness visits. Oh, sorry, during the annual wellness visits question and answers. I'm just reading the rest of your question. So yes, we will address that. And if it doesn't address it, just let me know, Christy, and I can elaborate. So first I want to address a few pre-submitted questions that we received before we do go to questions in the chat. So question number 1 asks, can a provider perform an evaluation and management services during an annual wellness visit? And yes, a provider can perform evaluation and management services during an annual wellness visit, but only if they're medically necessary. If an E&M service is provided in addition to the annual wellness visit, the documentation must clearly show that it is a distinct and separate service. In such cases, it should be billed with a modifier 25. Coinsurance, copayment, and deductible would apply to the separately billed E&M service, but not to the annual wellness visit itself. Question number 2 asked, we had a patient who received their cognitive and depression screenings 2 weeks before their annual wellness visit. Can we use those results to meet the annual wellness visit requirements, or must we repeat the screenings? And as long as both screenings are up to date and accurately reflect the patient's current status at the time of the annual wellness visit, the requirements for these portions have been satisfied. When completing the sections in the annual wellness visit, make sure your documentation indicates the location of these screenings within the chart. Question 3 asks, if a patient has been eligible for a Medicare Part B for more than 12 months, can a patient receive a G0439 subsequent annual wellness visit if the provider does not know if the patient has already received the G0438 initial annual wellness visit? And additionally, how can we tell if another provider has already rendered this service? So if the patient has been eligible for Medicare Part B for more than 12 months, they can only receive a subsequent annual wellness visit, billed as G0439, if they've already completed an initial annual wellness visit, which is billed as G0438. Medicare requires that the initial annual wellness visit happens first, and at least 11 full calendar months have passed since the patient's last AWV. The initial annual wellness visit establishes a baseline health risk assessment and prevention plan, while the subsequent annual wellness visit updates that information. If a provider is unsure whether the patient has already had an initial annual wellness visit, billing a subsequent annual wellness visit could lead to a claim denial. So to prevent this, it's important to verify the patient's annual wellness visit history. Providers can do this by checking eligibility systems, reviewing prior medical records, or looking up Medicare claims. And this will also help confirm whether another provider may have already performed this service. So just to be clear that you must provide an initial annual wellness visit before you provide that subsequent annual wellness visit. And I'm going to give you just an example of that. So if you forget to do the initial, and say the patient has been eligible for Medicare since January of 2022, but they never received and they were never billed for G0438, which is your initial annual wellness visit, you could still bill for the G0438 for the first annual wellness visit in 2026, assuming all AWV elements are documented and there's no conflicting preventive visit that was performed during that applicable frequency period. So even if they started in 2022, if you haven't done it, you could do their annual wellness visit, that first one, right now. So Medicare does not put a time limit on that. So question number 4 asked, what would need to be in the documentation when performing an annual wellness visit on a patient with mental disabilities or cognitive decline and was unable to perform questionnaires on their own? For a Medicare annual wellness visit involving a patient with cognitive impairment or mental disabilities, documentation to state that the patient was unable to independently complete required questionnaires, such as the health risk assessment, due to their condition. The record should identify the caregiver, family member, or legal guardian who provided the historical information and confirm the annual wellness visit components were completed through caregiver interview, chart review, or clinical observation as appropriate. It should also document completion of required elements such as medication review, functional status, safety assessment, and any cognitive evaluations performed, while also clearly stating any limitations. The note should ultimately support that all reasonable AWV requirements were met despite the patient's inability to self-report. And our last pre-submitted question asks, what is the top denial reason for AWVs? And the top denial reason is GBI09, and this occurs when required documentation for the annual wellness visit is either missing or incomplete. And that can include missing forms, an incomplete health risk assessment, or provider notes that don't include all required elements. In short, the visit wasn't fully documented according to requirements. To avoid these denials, it's important that all AWV components are fully completed, accurate, and submitted on time. And it looks like we've are at the end of our scheduled webinar time. So I know your time is valuable, and I really do appreciate with you staying with me as we cover this topic and these additional questions. However, to keep us on schedule, I'll move forward. If we didn't get to your question during today's presentation, we will follow up with you after the webinar. Please take a moment to complete the survey and share your feedback. We'll use your feedback to develop topics for future educational events. And you can access the survey by either clicking the link in the chat or visiting the Qualtrics page, the CMS Qualtrics page after the webinar. And it looks like this with that little yellow triangle. In a few minutes, you'll receive an email thanking you for attending, which includes your certificate of achievement and a link to the survey. If you need contact hours for continuing education, they'll also be in the email. If you don't see it, check your spam folder. If you called in, email us at wps.gha.education@wpsic.com with the webinar name and phone number, and we'll send you your certificate of achievement. If you think of any additional questions after today's event, you have 7 days from today to submit them. Send them to our education mailbox at wps.gha.education@wpsic.com, and that is in the chat, and put the title of this webinar in the subject line. However, if you have a claim-specific question, please direct those questions to our customer service department, as we don't have access to your claim information and they're therefore unable to look up claims. Also remember, we can't accept any type of PHI or PII via email. Finally, on behalf of Mary Sue, myself, and all of Provider Outreach and Education, thank you for attending today's webinar on navigating the ins and outs of annual wellness visits. As a reminder, this presentation will be posted as an encore presentation on the Training Center page on our website. Remember to take our survey with the link provided. We look forward to your survey comments and hope to have you join us at future events. You may now disconnect.